Hi, everyone. Thank you so much for joining us today for our webinar event, Understanding and Addressing Race-Related Stress and Trauma for Black Americans. My name is Emily Moore, and I'm going to be moderating today's webinar event. And I am joined by Dr. Ben Druss, the director of our center, the Southeast MHTTC, who will be introducing today's speaker. Just would like to remind everybody that today's event is in listen-only mode, so you won't be able to unmute during the presentation. And I'd also like to remind everybody that if you'd like to share questions or comments, those are available to you in the chat feature or in the Q&A feature at the bottom of your screen. I'm going to go ahead and turn it over to Dr. Druss so that he can introduce today's speaker, Dr. Sierra Carter.
Thanks so much, Emily. So it's my real pleasure to introduce today's speaker, Dr. Sierra Carter. Dr. Carter is an associate professor in clinical and community psychology at Georgia State University. A common theme throughout much of her work has been examining how racial discrimination as an acute and chronic stressor affects development and exacerbation of chronic illnesses and stress-related disorders across the life course. Her research program also examines how racial and cultural characteristics, such as racial identity, Afrocentric worldview, racial composition of communities, and place-based factors influence health utilizing a risk and resilience framework to further illuminate what may buffer the psychological and physical health impacts of racial discrimination. Her research aims to aid in improved identification of mechanisms that can be targeted in prevention and treatment efforts to reduce racial health disparities. Dr. Carter, it's wonderful to have you here. I'm really excited about your talk. Thank you.
Thank you so much, Dr. Druss. I'm going to go ahead and share my screen so we can get started. I'm so excited to be able to talk with you today about some of the work that I do. I will say that for today's talk, I'm going to be focusing primarily with my clinical hat here for the providers in the room. But if there are any questions about continuing research in this area, we'll touch on that as well. And we can talk through that and any of the questions that you might have. So for today's talk, I'm going to be really focusing on understanding and addressing race-related stress and trauma for Black Americans specifically. Just to give you a brief overview of what I'm planning to chat with you all today about is I'll first start with mostly definitions and some discussion about why this work is important, an overview of race-related stress and trauma and its consequences. I'll then move on to what are some challenges and clinical issues that often come up when trying to identify racial stress and trauma, and then give some methods to identify this process and ways we have found in the research, but also in clinical practice to heal from racial stress and trauma. What you'll hear throughout this conversation is I'll be using racial stress and trauma as well as racial trauma interchangeably. I think the wording for this has changed over time and also is, I think, an interesting paramount, particularly after the murder of George Floyd, as how important this work is. Also, there are going to be some learning objectives that I hope you take away from this talk today. I want you to have an understanding of racial stress and trauma if you don't already, and what that looks like, what it can appear like in a clinician's viewpoint, as well as how that affects communities. I'm also in the community psychology program here at Georgia State University, and how important context is to understanding this type of work. I'm also going to talk about assessment tools so that you can understand what are some ways you might want to add to your current assessment tools, as well as therapeutic strategies to think about as you continue to learn about this area. And I'm also going to have some resources that can potentially help you as you continue on this journey, including strength-based and resilience-based processes that are important to consider in this work as well. And so to get us started, I started doing a number of these talks, as you can guess, after the murder of George Floyd. But what we know is that racism, racial trauma has been a longstanding issue in Black lives. And what you'll see from these images is that due to police brutality, but also due to a number of other factors, Black people are losing their lives injusticeably from the experiences of oppression. And what my work has really focused on is not only naming racism as an important contributor, but also when you name something, you can more readily identify root causes that could be linked to racism across the lifespan. So I consider myself a person who thinks about the stress of racism across the lifespan. And my, lifelong goal since I was an undergrad and getting into this research was I want Black people to live longer and also thriving lives that they already deserve, and identify that for them and amplify the things that Black people already utilize to be able to support their well-being and longevity. So I'll first start off by talking about the risk and prevalence of trauma across the life course. There is a lot of research in the trauma space, and as clinicians, you have probably received a lot of training or some training in trauma world, but maybe less so in the racism literature. So I wanted to start there just to give you an idea of the trauma world and disproportionate effects of that for Black Americans. So research suggests that Black youth and adults have increased prevalence and risk for trauma exposure. Almost 65% of Black youth report traumatic experiences compared to 30% of their peers from other races. We also know that this increased exposure to trauma can lead to disparities in adulthood. So we're seeing this lifespan effect of trauma exposure. And Black adults may develop PTSD at higher rates than white adults, and that this clinical case can sometimes be poor. When I say poor, the research on this is interesting in that Black Americans who do come in for clinical services for PTSD do get better. But what the research is showing is that Black people who come in for treatment have a longer course with PTSD treatment. It takes longer to get better, and it's a slower process. And that led to a lot of conceptualizations of really what is the cultural context that might be missing from understanding the best methodology for treatment. So we also know that Black people have significantly higher rates of objective life stressors, such as witnessing violence, all the way up to receiving bad news or losing a loved one prematurely. And we saw that substantially when we're talking about the COVID pandemic, where we saw this disparate outcomes for Black Americans in this area as well. So this concentrated disadvantage, particularly in urban communities, places Black Americans at disproportionate risk for exposure to violence and trauma. Not until recently, by Dr. Bernard, have there been any theoretical models of early childhood adversity that really focused or even just acknowledged that racism could be a part of the picture of understanding trauma and chronic stress in Black lives. So most of the theoretical frameworks that I'll touch on here in a second have mostly neglected the multifaceted influence of multiple forms of traumatic stressors that disproportionately impact Black lives. So when I got started in this work, I was really interested in how racial discrimination worked across the lifespan, particularly amongst Black youth. And that was happening at age 10 to age 15. So this study was a 30-year-long study where they were tracking and understanding racism experiences of Black youth across time until they reached the age of 29. And now this group is at the age of 35 and older. And what was interesting at the time when I was doing this work is we thought in some ways that Black youth might be protected from racism. So there wasn't a ton of research on Black youth. We focused a lot on Black adults, and that research was emerging, particularly by Black scholars. But what we found was not only was racial discrimination that Black youth reported experiencing, at age 10 to 15 was related to accelerated cellular aging. So you're aging faster at age 29 than your peers. That was a link that was found to be related across time. But what was interesting to me in my work was that the mechanism driving this relationship was depression at age 20 to 29. And so that led me to questions about, if we start to recognize racism as a chronic stressor, just like how we identify trauma as a chronic stressor, and we start to see these ways that stress works for the mind and the body, then we can also think about culturally salient interventions potentially that can offset the toll of racism on lifelong trajectories. And so that's what really got me interested in thinking about trauma work from this lens that integrates culturally relevant factors like racism and understanding positions, as well as positions of opportunity, as well as ability to thrive and have lifelong longevity of health. So when we start taking that understanding and thinking about how we conceptualize trauma for Black lives, it leads to a more nuanced discussion about what treatment can look like, as well as where our thoughts about where we should be pushing for equity. And so I really focus on, like, what does health equity look like when we name a root cause like racism in our work as clinical psychologists, but also as humans, and what we think about really pushing forward initiatives that stop racism, as well as to promote healing for Black people. So in trauma and exposure and PTSD within context, what we know is that Black Americans have higher lifetime rates of PTSD and exposed to relatively more traumatic events than other races and ethnicities. These racial disparities persist even when controlling for trauma exposure and socioeconomic status. This is not to say that these factors do not matter, but when we look at some recent studies that look at racial discrimination, even when controlling for traumatic experience and socioeconomic status, racism experiences have a unique effect on PTSD outcomes, but also other health outcomes we're finding as of late. And how important it is to consider the place that traumatic stressors hold in our social power structures here in the US. What does this mean to be experiencing trauma, which can mean increasing police beats or police exposure across communities and urban environments? That can be stressful as well as traumatic, and in context can also be oppressive. Who gets disproportionately tracked? So thinking about how trauma works across the lifespan for Black people. And so one of the things that has been pushed by a number of Black scholars is this acknowledgement importance of racism as a chronic stressful stimuli, just like other traumatic stressors. And research scholars have said racism is a pervasive stressor that can get under the skin as well as into the mind. And stress related to racism-driven injustice is embedded within the fabric of our US society. This isn't an acute stressor. This has been a long-standing stressor across the history of the US, from enslavement to now. And so Dr. Janet Helms, one of the key researchers in the area of racial trauma in the 1990s, began talking about racial trauma as a concept, and even more so in the 2000s. But one of the things that stuck out to me in one of her research works was she noted that one reason that racial trauma is missing from contemporary trauma research, theory, and practice is that the broad historical foundations of racial trauma and its developmental effects often are sufficiently diffuse and pervasive that they do not provide objective evidence that a particular individual has been harmed more than others. And what she says after this discussion is, yes, racism is multifaceted, it is complex, it's across the lifespan, but that doesn't mean we shouldn't consider it. What she says is we have to have contextually driven research and practice that allows space for understanding the complexity, because if we don't, we can end up missing important features of what is happening, and also reduce the ability for Black people to see the well-being that they deserve. And so one factor that is getting increasing research as well as discussion in clinical practice that can account for the increased risk and prevalence of trauma exposure is racism. And the naming of racism has led to, particularly amongst communities, this identifying with racism as traumatic and this conceptualization of racial trauma. And so Dr. Robert Carter, not me, began defining what racial trauma looks like. And he described racial trauma as frightening, dangerous, upsetting, or violent race-based incidents involving a threat to the bodily integrity or self or others. Now, for all of the clinicians in the room and those who do trauma work, you can think about how that relates to our current definitions of trauma, criterion A traumas, what counts and what doesn't. Other things that he says is racial trauma overwhelms one's coping capacity and impacts quality of life and causes fear, helplessness, and horror. And then Carlson says in 1997, while not all racial incidents lead to PTSD, they can be emotionally painful, sudden, uncontrollable, cumulative, and elicit trauma symptoms. And so Dr. Monica Williams also has been a key player in understanding racial trauma and PTSD in our diagnostic frameworks, including the DSM-5, and really talks about what it means to experience racism across the lifespan, and really points out what makes racism both unique and aligned with traumatic stressors. But one thing that makes racist incidents unique in some ways from other traumas that can be more acute, one incident, is that racist incidents can be longstanding and often are, right? They aren't ending necessarily. You repeatedly experience racism throughout your lifespan often. And so this uncontrollable violation and assault on one's personhood makes the complexity of it in line with, we also know that Black people disproportionately experience criterion A traumas as well, makes it important to consider the complexity in the US of what Black people are experiencing. We already know in our research that there's substantial evidence indicating that racism, racial trauma can have negative effects on both psychological well-being as well as physiological health outcomes. All those studies show that multiple race-related encounters can occur on a daily basis for youth. Racial trauma or racial stress and trauma is often overlooked and not assessed in evaluating trauma experiences yet. There is hope for this work to continue in the future. One of the things that we are interested in as researchers and as clinicians is, why is it so overlooked? What can be going on amongst clinicians, amongst researchers? Why is it so hard to acknowledge the stressor when we have a lot of research that supports that racial discrimination and racial trauma have similar symptom profiles as other traumatic stressors? And one of the things that often happen is, with what Dr. Janet Helm said, is there's just a lot of different types of racial trauma that can occur, particularly in our current social or economic context. And so some of these include humiliating and shaming events, threats of harm and injury, social media, so online footage and discussions about police perpetuated killings. We are hearing more and more about Black people saying how harmful it is to repeatedly see over and over people that look like you on Twitter, on Facebook, on Instagram, experiencing police brutality, being killed because of racism. So experiencing or witnessing racial violence towards people who share your racial ethnic background, deportation and mistreatment of immigrants, both in real life as well as in social media representation, racial bullying online and in person, witnessing racial discrimination towards others. So I wanted to put the diagnostic manual of our DSM-5 definition of a traumatic stressor here for you all to see. And what you'll notice here is that over time, our DSM-5 has changed and what it considers to be traumatic. Sexual assault wasn't always considered a traumatic stressor. And so there's a choice that's made about what can be considered traumatic in our diagnostic manual, and this has changed over time. So when you think back to what Dr. Robert Carter wrote as a definition of racial trauma, and some of the similarities that you see in our current DSM-5, you can think about what choices we make in our diagnostic manual and if racial trauma might be important to fit within this diagnostic framework or possibly not. And some research scholars note that racism can be considered a potentially unique traumatic stressor and traumatic experience because of its historical legacy in the US and multi-systemic effects. And when I worked in the VA, but also as a clinician at Grady Trauma Project, which is a research-focused study at Emory University, I saw patients who experienced high levels of trauma exposure. And when I was treating one patient for PTSD, for a criterion A trauma that was separate from racism, that was the same time that Eric Gartner was killed. And one of the things that he said to me was, being Black, my traumas don't end. And that really stuck with me across time and even today about what it means to really understand racism, racial trauma in the context of the US of being Black, and how longstanding these issues have been in the lives of Black people, as well as across generations. And so there is a discussion and an ongoing one about racial trauma fitting within our diagnostic manuals or not. And there are multiple camps, but two specifically that I'll just touch on of saying, yes, we should, and what you'll see in that last circle is, yes, we should put this in our diagnostic manual. Racism needs to be recognized and acknowledged in order to engage in efficacious treatment. And then there's another camp that also says, I'm a little scared because racism, unlike some other things that we talk about in our diagnostic manual, is not an individual pathology or a disorder. This is something that is done to someone else. We need to be careful about putting it in a manual that uses categories to identify pathologies and disorders. And I think both camps have very important points here. And I think there are ways to think carefully about where you might align, where you might think for racial trauma. But one of the things that's important to note is that both camps agree that racism can be traumatic. Some other prominent scholars of color note a lot about what racial trauma looks like and important considerations for the our diagnostic manual. So one of the things that Carter says is it's important to note that we are not categorizing normal responses to racism as disordered. And Dr. Tamar Bryant Davis also says that similar to rape and domestic violence, racist incidents are the problem and the root problem of the disorder. People should not be stigmatized as problematic when they are responding to emotional and sometimes physical assaults to their integrity. And Dr. Green says that post-racism distress is a normal response to an abnormal experience or a sane response to an insane stressor. Important notes from scholars. And as we think about all of these things that scholars have noted, as well as ways in which racism shows itself on TV screens across the lifespan, you can think about things that are happening in our US society, and you might be seeing in your clinical environment, but there's not enough kind of discussion or assessment protocols around racism. For example, I would get calls all the time from family members, community members around, what do I do when my kid is, watching a TV and then it automatically shows police brutality, right? I wasn't ready to have that conversation about racism with my 8-year-old, but the conversation is here. What are the strategies that you utilize to socialize Black youth around racism and racial trauma? What should I be doing, right? All of these questions are coming up in clinical practice as well as across Black lives. And what does it mean when you have parents who are stressed out, not only for their kids, but for themselves? And they need to be well in order to take care of their kids who might be experiencing racism themselves. There's just a lot of foundational, important knowledge that we need to be providing to Black people, as well as to Black communities around issues of racism and racial trauma. And so understanding the lived experiences of Black Americans requires a racial health equity lens and a historical consciousness. And so that same patient that I talked about before noted to me that some of us did not die like Eric Garner. We're still here. There are people, Black people every day who are experiencing racial injustice that aren't on our TV screens, but are experiencing police brutality, are experiencing racial injustice, are experiencing oppression across different contexts that aren't something that is publicized, but is causing damage to livelihood. And an important point about this, I think, is when we think about our history in the US and we have a historical consciousness, we begin to unveil how longstanding this is and how we have to make direct efforts towards health equity in order to challenge as well as to be clinical providers that are effective in engaging in racial trauma work. Just so that you have an idea of how longstanding this research work has been in the area of racial discrimination and PTSD symptoms, we already know that racial discrimination is related to all of our current symptom profiles of or symptom clusters when we think about PTSD, including avoidance, re-experiencing symptoms, hypervigilance and arousal, negative mood, and self-esteem. We also know that it's related to a number of other factors that we often study in our trauma worlds around depression, sleep difficulties, somatic symptoms, irritability, anger, and concentration problems. So one of the things that I want to touch on even further is how important it also is to, with that acknowledgement that racism is affecting a lot of PTSD symptoms, is also how it can look when we think about different age ranges across the developmental life course for Black people. And so we know that exposure to race-related stress and trauma, as well as racial trauma, can feel and be experienced differently based on age and developmental stage. So when thinking about clinical work, this looks differently for a 10-year-old than it does for an adult who might have more long-standing experiences versus a 10-year-old who might be experiencing it for the first time. We also know that puberty can have an effect on how that stressor can affect that individual, as well as how they interpret the events of racism. We also know that manifestation of trauma symptoms and as well as depressive symptoms are really important to think about for youth. One of the things that I didn't talk about with the study that I did is when depression was that mechanism driving the relationship between racism and accelerated aging, is that we saw amongst those youth is that there was an effect on self-esteem, thoughts about self-control, as well as thoughts about overall hope. And so we're thinking a lot about with what depression symptoms can mean, right? In the context of experiencing racism, what does that do, right? Racism is coming at my integrity, my bodily integrity. So this is something I can't control. So therefore, what does that mean about me in this US society that I'm experiencing something based on the color of my skin that is not something that I can get away from, right? I can control. What does that do to Black youth? It also can influence how people cope with racism over time. So maybe the first time that you experience racism, you're not quite sure, but maybe you have a supportive network that influences your ability to cope with that racism. So the next time that you experience it, you go directly to that effort. And so there are some developmental standards to think about, but also if maybe you haven't experienced racism until maybe you go to college, right? How detrimental that potentially could be for a first-time experience of not being able to potentially have coping resources to utilize in that experience because this is your first time experiencing it. And one of the things that I think in taking a strength-based lens to Black people's lives and doing some of this research is how important family and community systems are to how Black youth interpret race-related stress and trauma or racial trauma, and how they are, and how that influences their identity, their self-esteem, and their progress in health and wellness. So Dr. Farzana Salim created this beautiful model of thinking about developmental ecological model of youth experiences of racial trauma, where she identifies how developmental age can influence racist events, and how important family-related processes, school-related processes, community context is to understanding PTSD-related symptoms and response. And I think that's an important consideration in thinking about for treatment that I'll get to towards the end of the presentation. Our last consideration before we get into kind of methods and treatment considerations is there's an increasing amount of work talking about the intergenerational impact of racial trauma experiences. I like to tell people when I go to a lot of trauma conferences in the past, one of the things that would come up a lot, and importantly, was the Holocaust and intergenerational trauma effects. And one of the things that kept coming up for me was like, oh, there's no discussion around slavery or enslavement for Black people. I wonder why that is. And there ends up being a question around an acknowledgement about our US history and how it could be very similar in some ways to how we think about other intergenerational horrific experiences by other groups of people. That we already know are also linked to future well-being across generations, like the Holocaust. And so we have limited research on the impact of slavery on current generations of Black people, but we're starting to gain some, and happy to discuss that at a later time with questions. And we also know that the traumatic effects of enslavement can be potentially transferred or have an intergenerational impact across generations. And so the effects of environmental challenges like enslavement faced by parents may be displayed by offspring, despite the children not encountering the same challenges themselves. And so Dr. DeGruy names this concept as post-traumatic slave syndrome. There's a whole book about it, if you would like to read more about it. But one of the things that she discusses is that there's a pre-self-esteem, anger, and racist socialization as psychological markers for PTSD syndrome, and explains intergenerational family discord and the numerous disparities in health outcomes across generations for Black Americans. And one of the examples she gives in the book is, I have to work twice as hard, as something that gets passed down as a phrase. And I know for my own family that is an interesting phrase that she comes up with, because I definitely heard it. And I know a number of other Black people have heard this phrase as well, but she talks about this in the context of enslavement, of having to work very hard and twice as hard in order to be looked at as half as good or as good as white people look, and how across generations this logic can get passed down across generations, and how that can affect Black people's health and well-being. Now, I think as a clinical psychologist and a researcher, what you can take from that is how things get passed down across time is important to consider, and including messages around how that can affect both mental and physical health. The way I look at it is that these messages can be both strength-based messages as well as messages that can be risky and increase vulnerability. And so the work that I'm currently doing, some of our research, is beginning to consider this intergenerational effect of racism and trauma, not only across the lifespan, but also before a baby is even born. One of the things to consider is how Black women experience maternal mortality and maternal health outcomes significantly disproportionately from other racial and ethnic groups. And why that exists across time. People have tried many different avenues of discussion, but when we started looking at this around 2020, the research on maternal health inequities when it came to Black people, we only found 11 studies that even mentioned racism as a potential culprit or avenue of discovery, of understanding why these disparities exist. And so we wrote this paper really focused on naming these processes that could be happening. And currently we're researching it even further around what are some things that could be happening that are rooted in oppression that can not only affect mom, but also fetus, and then the fetus's development, as well as when baby is born and across their lifespan. So what does it mean that mom stress across lifespan is affecting their offspring across time? And so now I'm going to get in, you have all this context. I'm going to get into some of the challenges and clinical issues that exist in identifying racial stress and trauma that I often hear, and also some of my colleagues often hear, and ways that we can address that. And so despite evidence of the detrimental effects of racial-related stress and racial trauma, there's a consideration, particularly amongst the scholars, Dr. Tama Bryant-Davis, as well as Dr. Gomez Diaz, who say that racial trauma can often be misperceived, dismissed, or unacknowledged by clinicians. And barriers often include this lack of historical consciousness, as well as current understanding of how racism works in our US society, and a narrow and exclusive scope of our current diagnostic criteria. And something that I think also needs to be named and discussed is a bias and discomfort surrounding racism-related topics. I think in our US, because we haven't had a reckoning with racial oppression and injustice, including enslavement across time, racism, discussions of racism can be this uncomfortable conversation to bring up and to influence treatment. So I think that's something that is an extensive barrier to actually thinking about this for treatment. And this oversight of racism and understanding race-related stress and trauma can impact a clinician's ability to properly assess, diagnose, and treat clients, make appropriate treatment decisions, and also build healthy rapport. One of the things that we see in PTSD treatments among adults is some high attrition rates in some of the research studies that we are doing with PTSD, or we have also seen that primarily exist as current trauma treatments without a racism-related focus. And a lot of that attrition rate is often discussed as, oh, these clients aren't ready yet for trauma treatment. But there is other considerations, is maybe because we haven't acknowledged the cultural context that Black people might be bringing in their experiences of traumatic experiences. We might be losing them when they first come in. They don't feel comfortable. They don't feel like this person really understands their experience. And so it may lead to a misunderstanding of the etiology of the trauma and the invalidation of their trauma experiences. So now let's get into some methods of identifying the process and how to heal from racial stress and trauma based on our current research and clinical practices that we see in today's work. And so with assessment, one of the things that we have discussed in our research along with colleagues is how we think about inquiring about racial stress and trauma, and how important it is to be direct and upfront around these conversations. Have you ever been treated in a disturbing manner because of your race? Have you witnessed someone else being treated in a disturbing manner due to their race, ethnicity, or cultural factors? This can be included in your assessment measures, but also in conversations. There have been adaptations to trauma screeners across time, including trauma screeners that we currently use, including the UCLA, the life events checklist. Sometimes people have added in questions of racial incidents, and I'll give an example. When I was working at the VA and when I was working at the Grady Trauma Project, when there wasn't a context for assessing racism or racial trauma, often Black patients or Black participants would not identify this as a space to talk about racism unless directly asked. So for example, in one of our research studies at Georgia State University, when our topic was on trauma and racism, in the trauma event inventory, that person noted a number of criterion A traumas, but not until we got to racist incident did we hear about a racist incident that fit into the trauma events inventory, where this person was in school and was held at gunpoint by the police officer on the school staff and pinned to the ground. This was very traumatic for this participant, but was not what they decided to put in the trauma event inventory at the time. And I think that's an important consideration about how our society views racism and what Black people might feel fits into the societal frame that's rooted in a lot of white supremacy. What can we say fits as a traumatic stressor? If we don't feel like you would acknowledge as a traumatic stressor, why would I put it in our current life events checklist or UCLA right? And so we have actively tried to add questions that ask about racism in our current trauma screeners. There are also measures of racial discrimination, including the unrest by Dr. Monica Williams, UC's Index of Race-Related Stress across adolescents. There's also for adults. There's also a measure of how activating racism-related stress is. So you can get an idea of how much anxiety as well as hypervigilance that it's causing Black people when they're experiencing race-related stress. And we also have the perceptions of racism in children and youth questionnaire to ask Black youth or other youth of color about their experiences of racism. And so you'll see here that a lot of our inventories don't currently have information about racism in it, but sometimes these racist experiences can fit into our criterion A traumas. But again, Black people might not know that this could be something that can be talked about in a clinical context. And so I'll just briefly talk about some of our current pilot data that we're doing where we're assessing both for PTSD related to criterion A traumas amongst people who are living in urban contexts in Atlanta, Georgia, primarily women. And so some preliminary findings here that I think are influencing the ways that we move forward is we gave them a question, a screener on race-related stress. And we also got we also administered the claimant's PTSD scale for the DSM-5 for both a racism-related stressor that they identified as their worst racism-related stressor, as well as their other criterion A traumas that could include sexual assault, natural disasters, car accidents, et cetera. What we found so far, and we're still looking at this even further, is for those who had met PTSD those who had the screener for race-related stress and also had a criterion A trauma, all 5 Black women who met criteria for PTSD in our study here also met criteria for PTSD from racism-related trauma. And what has been very interesting in this study is how much, particularly amongst the Black women that we are working with and aligning with and understanding and processing some of these results so far, is that Black womanhood and experiencing of racism completely plays into other experiences of what we consider today as criterion A trauma. So being a Black woman and experiencing sexual assault may look differently than a white woman experiencing sexual assault who has experienced racism potentially across their lifespan. There's a different way in which they might move in the society that can influence their PTSD symptomatology, and also, I would argue, how we would treat it. One of the things we also did was we centered Black women in particular in this study and did qualitative data analysis. And something that should be noted is that these interviews began in 2020 during the Black Lives Matter movement. And we focused on understanding how people experienced racism across their lifespan, but also what strength processes that they utilize to offset that toll. And we're starting to see some themes that are coming out amongst around 30 Black women participants so far. One of the things that's coming out is around centrality of identity. So how important race is to identity, as well as transgenerational strength. So not only is enslavement a process of significant risk, but they talked about across generations, how much Blackness and what the messages, positive messages that have been passed down about Blackness is important to their strength and recovery from racism. And so you'll see some of these quotes here. One of the things that was said is, you know what's right and your Black is beautiful. Don't go off on nobody else's opinion, just go off of what you think. And one person also said, oh yeah, all the time, they always used to tell me, my parents, still to this day, to be proud to be who you are. Yeah, so I'm very proud to be who I am and in my skin. Like I'm very, very proud of it. We also had themes around dehumanization and fear of safety that align with what I've talked about before around how racism works in our US society. And some of these quotes really focus on some of the things that the Black women in particular were discussing around their experiences of racism and racial trauma. And that can include your skin is a weapon to them, and you don't hear stories happening to other people and to other children. They write you off as a number, and that impacts me because that's my husband and I want him home. So there was a lot of discussion about Black community wellness, not only me as an individual, but how I want the people around me to be safe and fearing for their safety. And so in thinking about how this influences how we assess and treat, it can have considerations of deciding who to assess. Do you want to give a standard trauma treatment, or do you want to give a very contextually driven assessment and treatment? Being aware of one's own cultural heritage, bias, and limitations. So these conversations around racism can come across differently based on your own race, ethnicity, and privileges and identity. Being informed and sensitive and respectful of other people's heritage and experiences. This comes back to having this historical consciousness. So knowledge and understanding of historical and current social political factors that affect communities of color. Skills and tools, so sending and receiving culturally adequate verbal and nonverbal messages in the clinician's room and in a therapy context, and being able to identify potential weaknesses that you need to gain further knowledge about, I think are critical, and happy to discuss that even further if people have questions about that. One of the things that you saw from our mixed method study is about this fear of safety. And that goes along with how I think about treatment processes and how important it is to create a safe space for both therapists and clients to talk about racial trauma. So that therapeutic context is so important for influencing safety and feeling safe and disclosing racial trauma events. And that includes the therapeutic relationship focus, so the relationship that is built and rapport that is built that is open to this conversation, as well as what the therapeutic process focus is. So if there is no conversation that is allowed around my racial identity, my cultural context, my strengths as a Black woman, then I won't feel potentially comfortable with talking about that in our therapeutic process if you consider this trauma treatment of prolonged exposure or cognitive processing therapy as being strictly aligned with those factors and not allowing for cultural context. Another thing that is important with these conversations is really to think about belief and support as being important, acknowledgement as well as belief that these experiences are real for Black people. So some common steps in processing race-related stress and trauma includes acknowledging, sharing, building the safety and self-care, allowing a space for people to grieve. As I acknowledged and discussed very early on in this presentation, is that Black people have objective life stressors more than other races and ethnicities, including the loss of loved ones. And that can include loss of loved ones due to oppressive systems as well as oppressive practices. How Black people might have shame and self-blame around racism experiences, how they might be angry, right, at systems and structures that perpetuate oppression. And then they might have coping strategies that might not fit in our Eurocentric norms of what we consider to be effective coping strategies, right? So if I want to have, for example, resistance strategies where I decide to protest, let's not take away that this might be an important and potentially healing strategy because we haven't understood how racism as a stressor have efficacious coping strategies related to resistance to that oppression. And so I'm going to go a little quickly here in our current PTSD treatments, but this has been a lot about my own experiences, but also reading in the research literature, as well as from colleagues around some important things to consider when you're doing current trauma treatments. So some of the things that can come up often in our current treatments can be things that could exacerbate risk. So with racism, work that I've done with cognitive processing therapy, for example, often we think about stuck points with our current trauma treatments. But I often argue that Black people aren't stuck in their racism experiences. It's not a cognitive distortion that you need to challenge necessarily or restructure. But there are parts of this that I think are important to think about. What am I trying to do when I am acknowledging and treating the race-related stress that someone's bringing into the room? And also important to think about how participants label their experiences. And so sometimes, because of our societal socialization around racism, people might not know that it's okay to name racism as traumatic for them. And so it's important to consider asking questions around how people label it, because we often get people say, oh, well, this is something I just have to get past. Right? And allowing the space for saying and having a conversation about how traumatic this could be, how there is okay to have space and to heal from the racism that you've experienced. And I still think that there's more research that's needed in this area across the lifespan to really think about trauma-informed care that acknowledges racism and how it could play a role in symptom presentations. And then this last piece is really focused on us as providers, right? These interventions that we can consider have multiple layers, sometimes for clinicians, we think we have all the knowledge to be able to treat all the different disorders, but because racism is so multi-layered and systemic and structural in nature, a lot of times we need to rely on communities, particularly Black communities, to understand what their healing looks like. For example, there have been radical healing circles around racial trauma for a very long time, and maybe coming to see someone in a therapeutic context for individual treatment may not be their answer, right? So collective traumas like racism might need a collective response. And then healthcare providers like ourselves can also be engaged in activism and advocate for social justice to further end injustices related to racism. And so just to briefly give some resources here, around culturally competent considerations for Black youth and families, and this can also go for adults, is really thinking about attitudes and beliefs around systems, right? I might not trust your Eurocentric center to be able to help me to process racism, and those can be barriers to getting treatment for trauma, racial trauma in particular. There could be access barriers to your space for treatment. And then often we don't have a lot of assessments that really acknowledge cultural strengths and as well as risk. And I can talk about those if you would like to hear more around how you're socialized around racism discussions, how your Blackness can be uplifted in your racial identity, how your Afrocentric worldview can also be effective in building social support that can offset the toll of racism. And so there are a number of frameworks that are utilized to really discuss radical healing from racism. This one by French et al. Is really important to think about when thinking about context or Eurocentric values of coping with other types of stressors that might not quite fit how we think about healing from oppression. And so I'll end with some take-home points. And so in order to address racial inequities related to PTSD in Black American communities, we must first acknowledge that trauma experiences for this population are rooted in oppressive context. And it's important for our conceptualization of traumatic experiences to be inclusive of racial stress and trauma. And given our current and continuing social political climate in the US, as well as our legacy, it's important to think about novel ways to engage Black Americans around therapeutic interventions for PTSD and related to racial trauma. And I think there is an ongoing need for self-assessment about our comfort addressing topics of race and racism, and our role in fostering an environment that is safe for patients and clients to disclose and process racial trauma that can be essential for healing. And so I have some reading resources here as well, and thank you so much.
All right, thank you so much, Dr. Carter. We have now reached the end of our presentation. It's time for question and answers. If you have any questions for Dr. Carter, please put them in the Q&A feature at the bottom of your screen. And in the meantime, I do want to answer a couple of questions that I saw in the chat regarding the recording and the slides and the certificate of attendance. So just to remind everyone, A recording of today's presentation, as well as a PDF copy of the slides, will be available on our Southeast MHTTC website in just a few days. And yes, there is a certificate of attendance. It is available upon completion of our SAMHSA required evaluation surveys. So if you have any questions or comments for Dr. Carter, please feel free to put them in the chat or in the Q&A feature at the bottom of your screen. We still have about 5 minutes for Q&A.
No, thank you for the thoughtful comments. Appreciate it.
I definitely agree with all of the comments in the chat section. Thank you so much for this amazing presentation. I don't see any questions in the Q&A feature as of right now. Did you have any closing remarks or comments, Dr. Carter?
No, I mean, I really appreciate everyone allowing the space and opportunity to talk about something that's really important to my heart. And I'm happy to, if you don't have a question right now, I'm happy to answer other questions through email if other people have them. But I think this work is evolving quickly, and I think we need to be ready for this conversation and continuous conversation about racial trauma. And so I'm glad that people in the room are really reflecting on that.
I do see 2 questions in the chat right now. One, I would like to hear more about your studies and what works in the therapeutic realm, or what can really help in that sphere.
Yeah, so my work, to be completely honest, is I came in as a clinical psychologist, and then I realized things were missing around racial trauma work. And so I started researching it. So some of the stuff that you saw was like, can racism be traumatic? Was my first question. But in the work that I've seen with scholars that I work with, including Dr. Aisha Metzger, Dr. Farzana Salim, that have focused on augmented focuses of trauma-focused cognitive behavioral therapy for youth of color, as well as thinking about augmentations for cognitive processing therapy, have focused on embedding strength-based processes like racial socialization. So for Dr. Aisha Metzger's work in particular, trauma-focused cognitive behavioral therapy includes a racial socialization component to it, where there are conversations with parents, Black parents, for example, around how they socialize their kids around the racism that they experience that could influence how they experience the traumas, whether that is a race-related trauma or not. And that has been continuous in development of how that can be even more efficacious than our traditional trauma-focused treatment for youth of color. Similarly, Dr. Monica Williams has been doing a lot of work around ways to think about culture and context, as well as racism or racial trauma in the context of interventions that include not using necessarily this cognitive distortion practice that is in a lot of our trauma treatments, this challenging without acknowledging practice. And so a lot of this can have, to me, has some acceptance and commitment therapy principles within it that allows a space for an acknowledgement of racism, but also value-driven living in the face of racism that I think is missing from some of our trauma treatments, particularly when race-related stress is high. And I still think we need to have some work about the uniqueness of racism and how it can integrate. A lot of our work currently in race-related stress work is either non-race-based or race-based trauma. And there's no room for how these things overlap, connect, integrate with each other. And I think that is a big missing picture. So even in our current trauma treatments, I think we have a ways to go in integrating our work together and really doing interdisciplinary science to further those treatments recommendations for you all.
Awesome, thanks so much. There are 2 more questions in the Q&A feature now. The first, I wonder how you would suggest that clinicians find the first 3 steps.
The first 3 steps of if I could get an understanding of which 3 steps, because I did talk about a lot today.
Marnie, if you could clarify that question in the Q&A or in the chat. And while they are clarifying that, we'll go on to the other question in the Q&A feature. Any thoughts on supporting young adults who are in treatment for mental health and have developmental differences and may not perceive racism?
So I think that's an important consideration. I think we meet people where they're at, right? So a lot of what I see is the non-inclusion of this as a possibility, but that doesn't mean that you just need to go out asking, like if that's not something that's important to a youth to discuss necessarily, then that's not necessarily something that they're coming for development on. But I will say that racial identity development, right, can be an easy assessment that isn't labeling necessarily that you've had a racism experience, but allows space to think about how important being Black, for example, is to yourself. So if I had a participant who said, my racial identity is not my biggest identity. I think of myself in different ways that are not rooted in necessarily Blackness. I think about it in other ways. Womanhood is just really important. But then you might have a youth who says, oh, this is super important to me, right? And that allows the space to then talk about a lot of things that might be a factor, right? Do you think that this was due because of your race? Do you think that this was not due to be for your race? That ends up being a fluid conversation as a clinician that allows the space for the conversation. Doesn't mean that it needs to be a continuous conversation, but the biggest barrier I see is this lack of space that's allowed.
All right, thank you so much, Dr. Carter. Unfortunately, I don't see any further clarification on that question, and we are over time, so I think that's about all the time that we're going to have for Q&A today. I just want to thank you for such a great presentation and thank everyone for joining us. I'd like to ask everyone to please complete our evaluation surveys for SAMHSA. The survey will open automatically after leaving today's presentation, but we'll also put it in the chat for your convenience. And then there will be a link to that certificate of attendance upon completion of the surveys if you need that for your records. Dr. Carter, thank you so much again for an amazing presentation. And everyone, that is going to conclude today's event. Thank you so much, everyone.
Thank you.